Hi there, my highly valued and treasured viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for the healthcare sector workers. The virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management, and optimal treatment or clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I would like to humbly urge you to sit back and spare me part of your precious time to share some tips with you. So question 1 reads, which of the class 1 antiarrhythmic drugs listed below is the drug of choice in the management of WPW syndrome and tachycardia? Is it dofetilide, esmolol, procainamide, or diltiazem? I'll give you 10 seconds to choose the correct answer from that list of 4. So in my opinion, procainamide it is. Now, procainamide is the only class 1 antiarrhythmic drug among the list of 4 above. It is also known to be a drug of choice for most cases of tachycardia and or tachyarrhythmias in patients with WPW syndrome. Now, diltiazem, which is alternative D, is a non-dihydropyridine calcium channel blocker that is classified as a class 4 antiarrhythmic agent, which is known to block AV nodal conduction, but not the accessory pathway associated with the WPW syndrome, and thus could worsen the tachycardia and the clinical condition of the patient. Dofetilide, which is marketed as ticosine, is a class 3 antiarrhythmic agent, while esmolol, which is marketed as Brevibloc, is a selective beta-1 blocker, which is considered a class 2 antiarrhythmic agent with a very short half-life of 9 minutes to be precise. That's just a by the way and a clarification on why procainamide is the best option. Let's move to the next slide, please. HML, a 66-year-old male, presents to the hospital with an acute onset of shortness of breath and chest pain following a long transatlantic flight to Nairobi via Amsterdam. Upon presenting to the A&E, he is noted to have an altered mental status. Some of his vitals include a heart rate of 124 beats per minute, a blood pressure of 74 systolic, 40 diastolic, a respiratory rate of 26, and his oxygen saturation is 76, pretty low, on 4 liters via nasal cannula. And the clinician describes his skin as cold and clammy. A bedside ultrasound is done and it's suggestive of a PE and a right ventricular dilatation. So my question too is, how would you best prescribe this patient's clinical scenario? So are we dealing with distributive shock, obstructive shock, neurogenic shock, or a case of hypovolemic shock? I'll give you 10 seconds to choose the correct answer. So in my opinion, this is a case of obstructive shock, and we know that acute PE increases pulmonary vein resistance, causing blood flow from the right ventricle to be impaired. And as a result of that, There is limited blood return to the left atrium of the heart, to the left ventricle, and there is a decreased cardiac output by extension. Therefore, acute PE is considered an obstructive shock, although it may have components of cardiogenic shock. Inotropic or vasopressor support may be insufficient therapy since it doesn't address the underlying pathophysiology in a case like this one. Now, D-dimer is a product of fibrin breakdown and may be used as a biomarker in the assessment of patients with suspected PE. However, a high positive D-dimer doesn't predict a case of PE. Now, D-dimer is used for its negative predictive ability. In other words, a negative D-dimer is highly predictive of the absence of a PE. Now, in patients with a contraindication for fibrinolysis, catheter embolectomy and fragmentation or surgical embolectomy is reasonable for patients with massive PE as a mode of intervention. That's just as a by the way. So let's move to the next slide, please. LMJ, a 59-year-old Hispanic man, presents to the cardiac clinic with a past medical history of coronary artery disease, status post MI, which occurred a year ago. He is hypertensive, he's obese, and has dyslipidemia. He informs you that he continues to experience 3 to 4 episodes of angina every single week, and he says he would like to further reduce the number or the frequency of the angina episodes he is experiencing if possible. He has been smoking 20 packs of cigarettes per year, and he quit smoking 5 years ago. He denies taking alcohol or illicit drugs, and he is currently taking 81 milligrams of aspirin once daily, 10 milligrams of atorvastatin at bedtime, 10 milligrams of lisinopril once daily, 50 milligrams of metoprolol tartrate twice daily, and 30 milligrams of isosorbide mononitrate SA once daily. Now, some of his selected vitals include a systolic blood pressure of 155 and a diastolic of 83 with a heart rate of 60. His height is 70 inches and he weighs 230 pounds. He has a BMI of 330, pretty high. He's obese. And when you let him relax and repeat his pressure measurements, you obtain a systolic blood pressure of 153 and a diastolic of 87 with a heart rate of 58. Some of the selected lab results include a sodium level of 142, potassium level of 4.1, BUN of 14, serum creatinine of 1.1, AST of 25, ALT of 31, total cholesterol of 142, HDL of 46, LDL of 68, and a TG of 143. Given risk factor modification is the primary long-term goal for managing angina, and based on national guidelines, which of the modifiable risk factors listed below would be the most appropriate for improvement in the situation of Mr. LMJ? Is it dyslipidemia and hypertension, obesity and hypertension, obesity and smoking cessation, or dyslipidemia and smoking cessation? I'll give you 10 seconds to choose the correct duo from the list of 4. So in my opinion, B is the correct answer, the pair obesity and hypertension. Identification and modification of risk factors for angina should be the primary focus of long-term angina management in any patient who expresses a desire to have his quality of life improved. Risk factors which can be modified include, but aren't limited to, hypertension, dyslipidemia, tobacco use, sedentary lifestyle, obesity, and stress that we face in normal daily life. Of the listed risk factors, hypertension isn't currently at goal as per the JNC8 guidelines, which sets the goal at less than 150/90, if I remember well, for patients below the age of 60 years who do not have type 2 diabetes or chronic kidney disease, or the AHA guideline for the patients with ischemic heart disease, which sets the goal at below 130/80. Targeting further BP lowering, in my opinion, would be rational to decrease afterload in this particular patient, or to decrease the total peripheral resistance, leading to an improvement in the patient's myocardial oxygen demand. It would lower it, to be precise. Now, a BMI of 33 classifies this patient as obese or class 1. And weight reduction, dietary modifications, and exercise as tolerated should be recommended to this friend of ours. The remaining risk factors are already under good control, in my opinion, because if you look at dyslipidemia, LDL is 68 on atorvastatin, and we are told he stopped smoking 5 years ago. So I would go with the alternative B. Let's move to the next question, please. AJH, a 68-year-old white male in stage C heart failure with a left ventricular ejection fraction of 35%, presents to the cardiac clinic where he was seen 14 days ago, and during that time his vitals included a blood pressure of 128 systolic, 77 diastolic, the heart rate was 78, and a beta blocker was added to his therapy. Today he is hemodynamically stable. His blood pressure is 124 systolic, a drop of 4, and 73 diastolic, a drop of 4. The heart rate is 72, a drop of 6, and today he is euvolemic without complaints. He is currently taking 40 milligrams of lisinopril once daily, 25 milligrams of metoprolol succinate once a day, and 20 milligrams of furosemide once daily. Today the team intends to continue titrating the metoprolol succinate to the target heart failure dose as tolerated by Mr. AJH. If tolerated, what would be the ideal target dose for metoprolol succinate in AJH? Is it 100 milligrams or 200 milligrams or 50 milligrams or 150 milligrams? I'll give you 10 seconds to choose the correct dose. So 200 milligrams it is. Now the MERIT HF MERIT-FHF trial evaluated the use of metoprolol succinate in chronic heart failure patients. Now, within this trial, the target dose was 200 milligrams, with 64% of the patients reaching the 200 milligrams per day dose comfortably. The average daily dose for these trials was 159 milligrams, just for your information. In this trial, metoprolol succinate versus placebo decreased all-cause mortality by 34%, with fewer sudden deaths and deaths due to worsening of heart failure. In the management of hypertension, the maximum dose can be up to 400 milligrams of metoprolol succinate per day, but most patients in reality cannot tolerate such high doses. Just for your information. Let's move to the next slide, please. A newly diagnosed chronic stable angina patient is being evaluated for beta blocker therapy. My question to you is, which of the conditions listed below is an absolute contraindication to beta blocker use in such patients? Is it a heart rate of 65 beats per minute? Or is it sick sinus syndrome? Or is it stable heart failure with a left ventricular ejection fraction of 35%? Or is it an electrocardiogram PR interval of 0.15 seconds? I'll give you 10 seconds to choose the correct answer. So in my opinion, B is the correct answer. Absolute contraindications, as noted by the ACC/AHA chronic stable angina guidelines, include the following: severe bradycardia, pre-existing, high degree of AV block, sick sinus syndrome, and severe unstable left ventricular failure. Asthma and bronchospastic disease, severe depression, and peripheral vascular disease are listed as relative contraindications, not as absolute contraindications. Now, of the listed options, sick sinus syndrome is the correct answer. The other options describe a stable heart failure patient, which is an actual indication for beta blocker use. A low normal heart rate, but not a bradycardic state. That is where bradycardia means equal to or less than 60 beats per minute with symptoms usually not occurring until the heart rate falls below 50 beats per minute, and a normal PR interval where normal falls between 0.12 and 0.2 seconds, suggesting no AV blockade. Now we can define AV block as PR interval more than 0.2 seconds. Those are just for your information to clarify why sick sinus syndrome would be the best alternative amongst those four. Let's move to the next slide, please. So SSS, a 63-year-old Hispanic male patient, presents to the cardiac clinic for his routine follow-up appointment after a recent hospitalization for heart failure exacerbation. It is 1 week post his discharge, and he has a past medical history of coronary artery disease, status post 3 vessel CABG. He has heart failure with a left ventricular ejection fraction of 30%, according to the 2D echo that was done during the last hospitalization. He also suffers from type 2 diabetes mellitus. He's hypertensive and suffers from dyslipidemia. Now, SSS states that generally he doesn't have symptoms with activities of daily living or when he's at rest, though he experiences shortness of breath and fatigue on significant exertion. So my question to you is, to which ACCF/AHA stage and NYHA functional class does Mr. SSS belong? Is it stage C class 2, or is it stage C class 3, or is it stage B class 2, or does he fall in stage B class 3? I'll give you 10 seconds to choose the correct stage and class. in my opinion, A is the correct answer. According to this patient's 2D echo, he has systolic heart failure, which is a structural heart damage, and he was recently admitted for heart failure exacerbation, so he has had symptoms. Therefore, he is in stage C. Currently, he is in NYHA functional class 2, as he can perform activities of daily living without symptoms, which is a class 2 criterion. But he gets symptoms with significant exertion, therefore he can't be in class 1 at all. So that's just to clarify why he belongs to stage C, class 2. Let's move to the next question, please. It reads, which of the antiarrhythmic agents listed below is the most effective at pharmacologic cardioversion from atrial fibrillation to normal sinus rhythm in a patient who has been in atrial fibrillation for the past 10 days? Is it propafenone, dofetilide, dronedarone, or flecainide? I'll give you 10 seconds to choose the correct answer. In my opinion, dofetilide it is. Now, dofetilide, which is also called ticosine, is a class 3 antiarrhythmic agent and is the only listed medication with an indication for pharmacologic cardioversion to normal sinus rhythm in a patient with atrial fibrillation from that list of 4. Now, flecainide, just for your information, which is also called Tambocca, and propafenone, which is called Rithmol, are class 1C antiarrhythmic agents that are used for paroxysmal supraventricular tachycardia and paroxysmal atrial fibrillation in patients without structural heart disease. So they don't fit the correct answer in this particular case. Now, dronedarone is an antiarrhythmic that demonstrates the activities of all classes from 1 to 4 and is used for atrial fibrillation management but not for cardioversion. Remember that, underline that. It's not used for cardioversion at all. So the correct answer there becomes dofetilide. Let's move to the next question, which reads, a 53-year-old male patient status post 2-year cadaveric renal transplantation secondary to uncontrolled type 2 diabetes mellitus presents to the clinic with a past medical history of hypertension, type 2 diabetes mellitus, an NSTEMI that he underwent 3 years ago. He suffers from GERD and also suffers from neuropathic pain. Currently, he takes 81 milligrams of aspirin once daily, 20 milligrams of lisinopril once a day, 10 milligrams of amlodipine once a day, 50 milligrams of metoprolol twice daily, and he administers insulin 70-30 at a dose of 55 units in the morning and 30 units in the evening. He also takes 40 milligrams of atorvastatin at bedtime. Apart from that, he takes 10 milligrams of prednisone once daily, 700 milligrams of cyclosporin twice a day, 300 milligrams of gabapentin twice daily for his neuropathic pain. He also takes 1,334 milligrams of calcium acetate with each meal, and additionally he takes 20 milligrams of omeprazole once a day and supplements with multivitamins every day after breakfast. The immunosuppressive regimen of cyclosporin and prednisolone has worked and been overall well tolerated, except for his cholesterol and his blood pressure that have worsened over time. Remember, the prednisone will affect his glucose levels. Just have that as the back of your mind. So his most recent fasting labs include a potassium of 4.2, creatinine clearance of 1.2, that looks like serum creatinine 1.2. Sugar levels were 149 milligrams of glucose per deciliter. His A1C was 7.5%. The AST was 22, ALT 31, total cholesterol was 197, TG 223, HDL of 32, and an LDL of 120. His temperature is 98.4. He has a respiratory rate of 14 and a pulse of 65. His systolic blood pressure is 134. His diastolic blood pressure is 79. Now, after thoroughly evaluating this patient and his past treatment, the clinical team decides he may be a potential candidate for immunosuppressive agent modification or adjustment in order to maintain graft function and to improve his lipid profile. So my question to you is, which of the interventions listed below would be the most effective and safest option for our patient? Would it be to switch the cyclosporine to azathioprine and taper the prednisone? Or would you add sirolimus to his regimen? Or would you consider a steroid taper and continue cyclosporine at the same dose? Or would you taper prednisone and initiate mycophenolate? I'll give you 10 seconds to choose the correct answer. So in my opinion, I would consider a steroid taper and continue with the same cyclosporine dose. The patient's transplant specialist must be consulted when switching such therapy, and there are no studies on adding sirolimus to an existing steroid and cyclosporine based regimen for the purpose of improving lipids. There are no studies with switching to azathioprine and tapering steroids for the purposes of improving lipids either. And there has been at least one study evaluating the replacement of methylprednisolone for azathioprine in renal transplant patients, also on cyclosporine. In those receiving steroid taper, there was a 33% decrease in blood pressure medications per patient and a 12% reduction in cholesterol levels. This was also done without an adverse effect on the graft survival. There are no studies evaluating the tapering of prednisone and initiating mycophenolate. So alternative D does not hold water. It's not backed by any trials or studies. Now, a gentleman by the name Van Rentegem et al. With colleagues evaluated tapering of corticosteroids in renal transplant patients also on cyclosporine and mycophenolate, and showed a significant reduction in total cholesterol, triglycerides, and BP. And this was done without unacceptable increases in serious rejection episodes. So those many words clarify why C would be our best option. Let's move to the next slide, please. PLR, an 86-year-old Kenyan man who lives alone, presents to the cardiac clinic with a past medical history of atrial fibrillation and hypertension. Currently, he takes 5 milligrams of warfarin once daily, 12.5 milligrams of carvedilol twice a day, 10 milligrams of amlodipine once daily, and 40 milligrams of lisinopril once a day. His average vitals include systolic blood pressure of 146, diastolic 49 with a heart rate of 59. His lab values appear normal. And this patient PLR is tolerating his medication well, but informs you that he is progressively getting weaker, ambulating less, and his memory appears to be worsening. So my question to you is, which intervention listed below would best suit his management? Would you opt to continue with his current regimen, or would you increase the lisinopril dose to 80 milligrams once daily, or would you add 12.5 milligrams of chlorthalidone once daily after breakfast and titrate to a BP goal of less than 130 systolic and 90 diastolic as per the ACC/AHA guidelines, or would you increase the carvedilol dose to 25 milligrams twice daily and titrate to a BP goal of less than 140 systolic, 90 diastolic as per the JNC 8 guidelines? I'll give you 10 seconds to choose the correct answer. So I'd opt to continue with status quo. Now, additional BP lowering may increase PLR's risk of fall. Remember, he's 80 plus, he's an old man. Clinical judgment should be used to determine BP goals in clients with multiple comorbidities, history of falls, cognitive impairment, inability to live independently, or have limited life expectancy. Now, less stringent goals are appropriate in such patients like this very old man. The addition of chlorthalidone may increase his risk of hypotension. The ACC/AHA 2017 hypertension guidelines recommend a blood pressure goal of less than 130/80 for the general population, but this is an old man. He's not part of the general population. Now, increasing the carvedilol isn't necessary in this particular patient's case. It is a non-selective beta blocker which has alpha and beta blocking properties which can lead to decreased blood pressure and heart rate. Remember, his heart rate is already in the 50s. It's already controlled though, in my opinion, and additional lowering is not warranted. Additionally, the JNC 8 guidelines, if I remember well, recommend a blood pressure goal of less than 150/90 for patients above the age of 60 or older who do not have diabetes mellitus or chronic kidney disease. Now, increasing the lisinopril dose to 80 milligrams once daily isn't warranted, and it doesn't provide much benefit in lowering the blood pressure, and it may increase adverse effects in this gentleman like hyperkalemia, etc., etc. So I would opt to leave things as they are. Let's move to the next slide. AGT, a 31-year-old female patient, presents to the clinic for routine follow-up with a past medical history of allergic rhinitis and asthma. She informs you she is compliant with her medication and reports administering her rescue salbutamol inhaler thrice a month in the last 1 month. Some of her selected vitals include a blood pressure of 149/95 today. Now, during the last visit 28 days ago, it was 145/95, and 12 weeks ago it was 147/96. The pulse today is 79. 4 weeks ago it was 83, and 12 weeks ago it was 85. Her weight today is 168. 4 weeks ago it was 166, and 12 weeks ago it was 170 pounds. Her current medications include Advair 250/500, that is administered, or she inhales 1 puff twice daily. Apart from that, she takes 10 milligrams of Montelukast once a day and administers 1 to 2 puffs of salbutamol when necessary, up to 4 times daily. Some of our selected labs include a sodium of 142 today, 139 4 weeks ago, and 140 12 weeks ago. And to the extreme right you have the normal ranges. The potassium today is 4.5, it was 4.3 4 weeks ago and 4.4 12 weeks ago. The BUN today is 12, it was 15 4 weeks ago and 14 12 weeks ago. The creatinine is 0.9 today, it was 1.1 4 weeks ago and 1 12 weeks ago. And the glucose is 89 today, it was 91 4 weeks ago and 87 12 weeks ago. So based on the recent results, your clinical team diagnoses hypertension in this patient. So my question to you is, which intervention listed below would suit AGT the most? Is it a goal blood pressure of less than 120/80 with an initiation of hydrochlorothiazide after breakfast, or would it be a goal of less than 120/75 with the initiation of lisinopril, or would it be a goal BP of less than 130/80 with the initiation of propranolol, or would it be a goal of below 130/80 with the initiation of losartan? I'll give you 10 seconds to choose the correct answer. Personally, I would settle for alternative D, a goal of less than 130/80 and initiate the ARB losartan. This patient's goal, BP goal, in my opinion, is supposed to be below 130/80. The choice between propranolol and losartan is driven by asthma comorbid condition. Propranolol is a non-selective beta blocker and poses an increased risk of worsening of the asthma control in this patient, specifically by competing with the beta agonist salmeterol, and by also competing with salbutamol, which is her rescue inhaler, in the lungs precisely, and that would cause bronchoconstriction and would worsen the asthma control. Now losartan is a reasonable choice, but the potassium levels of this patient, which if I remember well were around 4.5 today, will have to be closely monitored, as it is in the moderate to high normal range at initiation. That's just a by the way. So let's move to the next slide, please. A 60-year-old male patient presents to the clinic with a chief complaint of a new onset of shortness of breath, decreased exercise tolerance, and an overall fatigue, but denies any history of prior cardiovascular disease. He has a past medical history of type 2 diabetes mellitus, allergic rhinitis, hypertension, osteoarthritis of both the hips and the knees, and dyslipidemia. Currently he takes 1,000 milligrams of metformin after breakfast and after dinner, and administered insulin decimir as her basal insulin at a dose of 40 units at bedtime, and also administered insulin aspart as her bolus insulin at a dose of 12 units before each meal. Additionally, he takes lisinopril at a dose of 40 milligrams once daily, atorvastatin at a dose of 20 milligrams at bedtime, and fexofenadine at a dose of 180 milligrams once daily for the allergic rhinitis, together with 1 to 2 tablets of paracetamol 500 milligrams up to 4 times daily when necessary when in pain. Some of the vitals include a blood pressure of 135 systolic, 77 diastolic, with a heart rate of 77 and a respiratory rate of 12. And when you ask about the pain, this gentleman classifies it as a 1 on a scale of 1 to 10. All the other labs are within normal limits. On physical examination, the HEENT is an abbreviation that stands for head, eyes, ears, nose, and throat. The PERRLA there stands for pupils, equal, round, reactive, light, accommodation. These are just to guide you in doing a thorough physical exam. The EOMI stands for extraocular movement or muscle intact. So there is no scleral icterus, there is no thyromegaly, there is no lymphadenopathy. The cardiovascular system looks okay. There are no murmurs, no rubs, no gallops, and the lungs appear clear to auscultation bilaterally. When on doing the abdominal examination, it appears soft but not tender, not distended, but there are bowel sounds. When it comes to the extremities, the 1 to 2 plus pitting edema bilaterally up to the knees. There could be issues with the heart here. There is no rash, there is no cyanosis, and there is no clubbing. Now the team goes ahead and does a 2D echo, which reveals a left ventricular ejection fraction of 35. The heart is failing, and there's also a concentric left ventricular hypertrophy noted. The right ventricle appears to be normal. Now, based on this provided information, your clinical team diagnoses heart failure, unfortunately. Now, to what stage of heart failure does this patient belong from the facts given? Is he in stage D of heart failure, stage C of heart failure, stage B or A? I'll give you 10 seconds to choose the correct stage basing on the given information. Opinion, he belongs to stage C. Now, based on the ACCF/AHA heart failure guidelines, this patient would be considered stage C heart failure given the noted structural heart disease. Remember the 2D echo results, and he appears to be currently experiencing symptoms. Once this patient is appropriately treated, the current heart failure symptoms may resolve, but the patient will still be classified as stage C heart failure because it's a structural heart disease and a prior or current symptoms of heart failure. The class will not change. That's just a by the way. Let's move to the next slide. Which of the durations of therapy listed below is associated with an increased risk for developing most cases of heparin-induced thrombocytopenia in patients who haven't been exposed to heparin in the past? Is it greater than 4 days, 1 day, 1 to 2 days, or 2 to 4 days? I'll give you 10 seconds to choose the correct answer. In my opinion, it will be greater than 4 days. Now, immune-mediated heparin-induced thrombocytopenia is associated with platelet reductions of over 30 to 50%, and in many cases also associated with the development of potential life-threatening thrombosis formation. It differs from heparin-associated thrombocytopenia, which is abbreviated as HAT, in that the typical onset of platelet reduction occurs after 4 days of heparin or low molecular weight heparin therapy versus within 48 to 72 hours for heart. That's just for your information. And there are a number of risk factors which are known to predispose patients to the development of HIT, which include the source of heparin. Now, studies show that bovine heparin causes HIT more frequently than the porcine version. Even duration of exposure counts, whereby exposure for over 4 days increases the risks, and even past exposure to heparin increases the risk, and the risk is higher within 30 days from exposure as opposed to a patient who was exposed 100 days ago. The dose of heparin also matters. It is greater in a patient who is being treated as opposed to a patient undergoing prophylaxis or one who undergoes flash dose just to deal with a line that has tissued. Even gender counts. It's greater in females than in males. And even the medical scenario may count. Post-operatively, chances of HIT would be greater in a cardiac surgery more than an orthopedic case, which would be more than a vascular case, which would be more than a general surgery case. Of the risk factors presented, the type of heparin based product, that is ultra fractionated heparin versus low molecular weight heparin, the duration of exposure to heparin or to low molecular weight heparin, and a recent history of receiving heparin within the last 100 days, especially within the last 30 days, as I said, are known to increase the odds of developing HIT by greater than 5-fold. Now, the type of medical scenario or setting in which heparin or the low molecular weight heparin is being used and the dose, whether it's therapeutic or prophylactic, are known to increase the odds of developing HIT by 3 to 5-fold. Now, the least influential risk factor is gender. Being female can increase the risks for HIT by 1 to 3-fold. Those are just by the way for your information. Let's move to the next slide. So the question reads, which of the statements below regarding monitoring of dyslipidemia among the adult population is correct? Is it baseline AST and ALT blood tests aren't recommended when initiating certain therapy? Or is it CK at baseline is recommended? It must be checked in patients who present with muscle pain and weakness, especially in the elderly, and hyperlipidemia treatment should be stopped if CK rises to over 10 times the upper limit of normal. Or is it C, to accurately measure the patient's response to statin therapy, recheck lipid panel 2 weeks after initiation of therapy and also after any changes in drug therapy? Or is it D, lipid therapy can be continued until liver enzymes reach 5 times the upper limit of normal, at which point lipid lowering drugs should be discontinued or dose reduced? I'll give you 10 seconds to choose the correct answer. In my opinion, B is the correct answer. Now, CK should be measured before starting lipid lowering treatment in all patients if possible and if feasible. it isn't necessary to routinely monitor CK in patients taking lipid-lowering therapy. CK should be checked if a patient develops, for example, myalgia. Now, AST, ALT, and CK levels are recommended at baseline. Safety blood tests are important to identify and limit the number of people in which certain medications are contraindicated. Now, 2 weeks isn't sufficient to check the effectiveness of statin therapy. Response to therapy can be assessed at 6 to 8 weeks from initiation of therapy. Response to lifestyle changes may take even longer, so that makes alternative C wrong. And I would just like to emphasize that statin therapy is usually held or the dose reduced when AST or ALT increases to 3 times the upper limit of normal on 2 consecutive occasions. Patients with mildly elevated ALT due to steatosis have been studied with statin treatment, and there are no indications that statin cause any worsening of liver conditions. So routine monitoring of ALT during statin therapy is no longer recommended. Now, in rhabdomyolysis, CK levels are elevated by over or equal to 10 times and often over or equal to 40 times the upper limit of normal and are associated with renal damage or impairment. That's just by the way for your information. Let's move to the next slide, please. The question reads, which of the statements below articulates the advantage of using a rhythm control strategy in the management of atrial fibrillation? Is it rhythm control will require less patient monitoring than rate control? Or is it that rhythm control may improve a patient's angina symptoms more than rate control? Or is it that rhythm control is easier to achieve and maintain than rate control? Or is it that rhythm control will significantly decrease mortality compared to rate control? I'll give you 10 seconds to choose the correct answer. So in my opinion, rhythm control may improve a patient's angina symptoms more than rate control. Now, rhythm control can improve efficacy in the heart's ability to contract and therefore move blood forward in the blood vessels. Rhythm control has more potential side effects and will require at least as much monitoring as rate control. The monitoring for rate and rhythm control is different. Now, current data demonstrates no difference in all-cause mortality between the two. A rate versus a rhythm meta-analysis was done to assess these two different approaches to treatment. It contained 5 trials that included a total of 5,239 patients, to be specific, with persistent atrial fibrillation or AFib that was considered likely to be recurrent. Now, no significant differences were observed regarding all-cause mortality, although a strong trend in favor of rate control approach was observed. That is 13% versus 14.6%, with an odds ratio of 0.87, with a 95 confidence interval of 0.74 to 1.02, with a p-value of 0.09. Now, there was no heterogeneity apparently between the two trials. The q value was 2.97 with a p-value of 0.65. So I would refer you to read the outcomes of that trial for more information. Let's move to the next slide, please. NKN, a 67-year-old male patient, presents to the cardiac clinic with a past medical history of STEMI status post a drug-eluting stent that was placed 4.5 years ago. He also suffers from type 2 diabetes mellitus. Currently, he takes 40 milligrams of simvastatin at bedtime, 81 milligrams of aspirin once daily, 25 milligrams of carvedilol twice a day, 1000 milligrams of metformin after breakfast and after dinner, and he subcutaneously administers 5 micrograms of exenatide twice daily. He confirms full adherence to his current regimen, and some of his labs include a TC of 140, a TG of 230, an HDL of 53, an LDL of 120, serum creatinine of 1.2, and creatinine clearance of 29 ml per minute. My question to you is, which of the recommendations listed below would make this gentleman NKN's management more effective? Would you increase the simvastatin dose to 80 milligrams at bedtime, or would you continue simvastatin at the same dose, or would you substitute simvastatin with atorvastatin at a dose of 40 milligrams at bedtime, the lower end of the high intensity atorvastatin regimen? Or would you add fenofibrate at a dose of 200 milligrams once daily to his regimen? Or would you add ezetimibe at a dose of 10 milligrams once daily to this gentleman's regimen? I'll give you 10 seconds to choose the correct answer. So I would substitute simvastatin with atorvastatin at a dose of 40 milligrams at bedtime. Remember, NKN is below the age of 75 years. He has a history of clinical atherosclerotic cardiovascular disease and is at a very high risk based on the ASCVD and multiple high-risk conditions. And he isn't on maximum dose statin. Remember, he's taking a fairly mild statin. Therefore, changing to a high-intensity statin with atorvastatin, the dose of 40 milligrams, would be the most appropriate step at this time. Now, continuing simvastatin at a dose of 40 milligrams would be inappropriate, since the guidelines recommend a high-intensity statin in such patients. If the high-intensity statin dose isn't tolerated, then a moderate dose would be appropriate. Now, increasing the simvastatin dose to 80 milligrams at bedtime would be inappropriate. This dose was evaluated in a randomized controlled trial. However, the FDA recommends against its use due to reports of increased risks of myopathy. Fenofibrate, on the other hand, isn't indicated at this time, since the TG levels are still below 500 milligrams per deciliter. Ezetimibe, on the other hand, may be considered for this case if the patient is on maximally tolerated statin dose and LDL level remains 70 milligrams per deciliter or above the 70 mark. Secondary ASCVD prevention and lipid management is based on high risk and very high risk. Now, patients meet the criteria for very high risk if they have a history of multiple major ASCVD events or one major event with multiple high risk conditions, e.g. age of 65 or older, hypertension, type 2 diabetes mellitus, current smoker, chronic kidney disease, congestive heart failure, and so on and so forth. Now, in both high risk and very high risk secondary prevention patients, should be taking high intensity statins if they can tolerate it. That's just to clarify why we would need to switch from a mild statin to a high intensity statin therapy. Let's move to the next slide. UMK, a 64-year-old male patient experiences a cardiac arrest and advanced CPR is currently in progress. Basing on his past medical history, the team feels his cardiac arrest is likely due to a pulmonary embolism, and they intend to administer alteplase. Currently, they only have an intraosseous access available. They're grossly limited. Now, my question to you is, which of the following would be the next best course of action or mode of intervention in this patient's case? Remember, you have to save a life. Time is muscle. Would you administer the alteplase at a dose of 100 milligrams IV with 10% as a bolus and the remainder over 120 minutes? Or would you administer the alteplase 50 milligrams via IV bolus? Or is it true that it's contraindicated and chest compressions may cause a rib fracture? Or is it contraindicated because it can't be administered via intraosseous route? I'll give you 10 seconds to choose the correct answer. So in my opinion, I would take chances and administer it by 50 milligrams IV bolus. Now, in cardiac arrest that is suspected to be due to a PE, thrombolysis may be considered. Ongoing chest compressions aren't an absolute contraindication to fibrinolytic therapy, and fibrinolytic agents may be administered via intraosseous access if need be. Now, given the clinical scenario at hand, a 2-hour infusion isn't practical and may not deliver the medication in a timely fashion to this particular patient. Now, according to the AHA, it is reasonable to administer alteplase 50 milligrams via IV bolus, which may be repeated once in 15 minutes. Now, if fibrinolysis with alteplase or tenecteplase is reasonable in cardiac arrest caused by suspected or confirmed PE. If patients receive alteplase for PE during a cardiac arrest, they should continue to receive antithrombotic therapy if return to spontaneous circulation, which we call ROSC, is achieved. I would just like to emphasize that tenecteplase offers a practical advantage due to low reconstitution volume and ease of administration. And massive PE, where there is a systolic blood pressure of less than 90, may initially present as a sudden cardiac arrest. Now, submassive PE in the scenario of a right ventricular dysfunction without hypotension may be managed without fibrinolysis in a few select cases. And fibrinolysis may be considered in patients with cardiac arrest due to STEMI. However, alternative management strategies exist, such as the PCI, if your hospital has a cath lab. Those are just additional points as by the way. Let's move to the next slide. Mr. EAO, a 40-year-old male patient whose past medical history is unknown, presents to the clinic for a clinical checkup prior to formal employment. From the clinical team's judgment, he is a disheveled, obese patient who is confused regarding the events surrounding his visit. His vitals include a systolic blood pressure of 210, diastolic 109 bilaterally, a tachycardic 116 beats per minute to be specific, and his tachypneic 24 breaths per minute. But he is a febrile. Now, because he is hypertensive and confused, you decide to treat him, but your choice of agent depends on his past medical history and your workup. So my question to you is, which of the statements below regarding the drug of choice is true or correct? Is it phenoldiazepam is the drug of choice in glaucoma, or is it nitroglycerin is the drug of choice in acute coronary syndrome, or is it enalaprilat is the drug of choice in bilateral renal artery stenosis, or is it true that verapamil is the drug of choice in heart block? I'll give you 10 seconds to choose the correct answer. So in my opinion, B is the correct answer. Nitroglycerin is a potent coronary and peripheral artery vasodilator and is appropriate for hypertensive emergency or urgency, including cases of acute coronary syndrome, of course, unless you have any evidence or suspicion of right-sided myocardial infarction or prior use of type 5 phosphodiesterase inhibitors such as sildenafil, tadalafil, or vardenafil within the past 24 hours. I'd like to remind you that the reason nitroglycerin should be avoided in these patients with right-sided MI is due to the fact that these patients are dependent on preload, which is the volume of blood returning back to the heart, and nitroglycerin can also dilate veins and increase its capacitance, thereby decreasing preload. Now, ACE inhibitors such as enalaprilat, which is an IV form, can cause a dilatation at different renal arteries and thus reduce the glomerular filtration pressure, which can cause acute renal failure in bilateral renal artery stenosis and is therefore contraindicated. The only time ACE inhibitors should be used in a patient with bilateral artery stenosis is if those stenotic renal arteries were stented open. Now, we do not have a history in this patient's case. Phenoldiazepam, which is marketed as colopam, is a dopamine agonist, and it should be used cautiously in glaucoma as it can cause a dose-dependent increase in intraocular pressure and should be used with caution in patients with glaucoma. So that makes answer A wrong. And then verapamil is a non-dihydropyridine calcium channel blocker which can slow down the heart rate by acting through negative chronotropic effect because of its inhibition of phase 0, which is the inward movement of calcium via the voltage gated calcium channel of the action potential within the AV nodal cells. So that contradicts what alternative D says. Now, all those many words are the reason why I strongly feel that B would be our best bet. Ladies and gentlemen, my highly esteemed viewers and listeners, that brings us to the end of part 33 of our MCQ series. If this video helped you in any way, I would like to remind you to give it a thumbs up and to like it. And if you haven't yet done so, I would humbly like to request you to subscribe to my YouTube channel. I would like to promise you that the best is yet to come, and I look forward to interacting with you in part 33 of our pharmacotherapy MCQ series. Thank you for always being there for me.